Oh, good morning, everyone. Welcome to Medica's first webinar session on behalf of the Diagnostic Network of Berlin-Brandenburg. My name is Jörg Hollet. I have the pleasure to introduce you to this webinar. I will make it very, very quick because we have a distinguished speaker today. So please let me start immediately. Topic of today is managing the SARS-CoV-2 pandemic. Which testing strategy should be used? Who are we, or what is the pitch of the day or the doing of the day? I'll give you the short introduction, then we start with the actual talk, and then we have plenty of time for a discussion. I'll come back to that point at the end of my presentation, how we proceed with the discussion. First of all, we in Berlin-Brandenburg are absolute proud member of a larger institution, which is the cluster of health capital. So managing all the health activities in the area, in the capital area of Germany. So Health Capital Berlin-Brandenburg is the overall cluster name. This is all funded also by the countries of Brandenburg and Berlin. And we as Diagnostic Network are very, very proud to perform also to take over the responsibility for all the fairs and activities in terms of diagnostics. Who is what is defining the region of health capital? We have 21,000 healthcare companies, around 400,000 employees in the healthcare industry. We do a significant amount of turnover. We have 30 pharmaceutical companies with more than 10,000 employees. We have more than 250 biotech companies and roughly 330 medtech and digital health companies in this area. So all of this is significant activity, and I'm very happy that you can see that. I think you've lost the screen, is that correct? And I have to correct that. Do you see? Is the screen now to be seen?
Yes, yes.
Yes, it is. Thanks.
Okay, good. Okay, then let me proceed with that. There is a vision, there is a purpose of all what we are doing. Basically, it's supporting the healthcare industry, the ecosystem in Berlin-Brandenburg, and this is very, very successful, to be honest. And so we are quite proud to move on here today. The network of diagnostic in Berlin-Brandenburg, so the Diagnostic Network in Brandenburg, we have had our birth 13 years ago in Hennigsdorf near Berlin. We now comprise around 75 members, and therefore thereof a lot of growing highly innovative companies in this area, diagnostic manufacturers, device manufacturers and suppliers, research institutions as well, applied science at that point, clinical and medical laboratories, and law firms and consulting agencies. So all of what we would need to promote the diagnostic overall. You can visit our homepage, diagnosticnet-bb.de. Then to move on, what is the idea of the Diagnostic Network? We are your all-around partner for the development of IVDs. It is so far not only a lobby institution or a promotion of the idea of diagnostic, but we do hand-on. We get our hands dirty. We take over responsibility, build consortia that deliver diagnostic products and activities and work towards the customer. So you have a biomarker you would like to get on the market and being developed. You would like to get it distributed around the world. You would like to get it validated clinically and the like, or develop new diagnostic test systems. That is what we do. Please contact us. We find the consortium that is helping you in your diagnostic idea. So having said that, we are currently present at the virtual Medica, so an experiment for us as well. Very much looking forward to not seeing all of you, but get in touch with you and in contact with you. We have prepared our presentation at the Medica more like a conventional affair, so with booths for all the individual companies. You see here the overview. Visit us at medica.diagnostic-bb.de. There you will see our distinguished members and exhibitors, and you can click on those booths, and then you can start to communicate further with the respective companies or exhibitors. So now today it's an absolute pleasure to enter into a topic of the day, managing the SARS-CoV-2 pandemic. Which testing strategy should be used? I think that's the question that all of us are asking ourselves. We have the pleasure to have Professor Hufert with us. He is a distinguished member of the great community taking care about diagnostics, especially in virology and in infectious diseases. He studied medicine at the University of Hamburg. He spent quite some time at the Bernhard Nocht Institute for Tropical Medicine. Very important, especially in those days, times today. These days, important stations have been the University of Freiburg and also the Georg August University in Göttingen. So that is giving you a lot of background and about his competencies. And since 2014, Professor Hufert is director of the Institute of Microbiology and Virology of the Medical University of Brandenburg, which makes us very, very proud that we have not only this university in Brandenburg here, but also people like Professor Hufert presenting them. And in parallel, as if this would not be enough, he is also a member of the Faculty of Natural Science at the Brandenburg Technical University. So that is linking together what we always try to do, the medical background with the technical background. So we are very, very happy to have you here today, Professor Hufert. And before I switch the word over to you, the microphone, first, a last remark on the a little bit on the housekeeping. We would like to activate the chat function, and if you have any questions during the talk, please do not hesitate to present them, to type them in the chat function or the question and answer function. Afterwards, when we have the session of discussion of the talk, then we will present those questions and read them aloud to the whole community, to everyone watching, and so that everybody can hear the question and listen to the question, and then we start the discussion and ask Professor Hufert to answer all the questions, and also we will involve maybe some other people for a more vivid discussion. So, having said that, no further ado, Professor Hufert, I'll hand the mic over to you. Very much looking forward to your talk. Thank you.
Thank you very much. You have to leave your sharing, please. So, hello everybody, and thanks a lot for a kind introduction. And I want to take all of you with me via the net in the field of virology, what is, I think, quite different than you might expect, because I will not only talk on SARS-CoV-2, but try to a little bit to explain you why we have such events like this, because these are the two topics. The one is, how do emerging infectious diseases really emerge? Where do they come from? And of course, the main topic is SARS-Coronavirus type 2. Okay, so that has nothing to do with the talk, you would think, but it's completely different. You are living in a virus sphere, and I think the majority of people are not aware of that, but we have the biggest genetic pool of diversity on this planet is from the viruses which come from the ocean. And that's very far away to SARS-CoV-2, I know, but just exercise in numbers, we have 10 millions and billions of viruses, 10 to the power of 30 viruses in the ocean. And if you bring them all on one line, you have 100 times the distance of our galaxy. So that's just that you know that viruses are all around you and that the whole system of life is regulated by viruses. Everything what is microscopic is regulated by viruses. And that is known until now almost more than 10 years, but has never been very recognized so very much. So quite clear, in evolution, every species has its own virus, and it's a co-evolution of that. And I think the reader will also join the life of tree. What you see here are there risk factors for disease emergence, transmission? Yes, we have more than 1,400 species of infectious agents causing disease in man, and 61% of those, they are of zoonotic origin, and 75% of those are emerging infectious diseases. If you look at these ones, which are coming now and come into the from the animal field into the human population, and the majority of these are viruses. So there is a tremendous outbreak like this, and emerging viruses coming into the field of humans. And that is quite clear why this is the case. We have global warming, we have a very high population density of humans on this planet, we have increasing poverty, we have wars, we have deforestation, and all that increases the risk of emerging infectious disease, especially of emerging viruses, tremendously. And today, the high mobility of people, animals, and goods, and the progression of the globalization, which goes very, very fast at the moment, makes a big increasing risk for emerging infectious diseases that they will play a major role. And SARS-CoV-2 is only one example. As you may know, we had the Zika outbreak. We had a big outbreak of Ebola in Africa, the biggest one we ever had. It was a very, very remote viral infection. And we had not so long time ago, West Nile virus, which conquered two big continents, Northern and Southern America. So that is something that is going on a continuous way. And of course, we had the SARS-1 outbreak in 2001 to 2003 in China, and from there all over the world. So SARS-CoV-2 is now the latest member of these emerging viruses, which made up their way into the human population, with a very big advantage for the virus is that it's very easily transmitted, and even before you get sick. And that makes it very, very successful for the virus to do its job, but it's also very difficult for us then to control it. And one key issue of all that is our flight network. There are mathematical models which have done that for the first SARS outbreak in 2004, that you can connect all the outbreak points and with the hubs of the flight connections. And so then it's quite obvious that if you have such a strong high mobility, you sometimes may get a lot of a viral load, as you can see here, leaving the plane as blind passengers. So SARS-Coronaviruses, well, they are also known since 2002, where the first SARS outbreak of SARS-1 occurred in China, and was at that time together with a group of scientists in Beijing. And it's an RNA virus with a big genome, and it has not that capacity of managing genetic differences as influenza has. That's different. It's not so very genetically flexible. That might be an advantage for us in controlling us, but we will see. It will turn out later. And coronaviruses, when I was starting in virology in the beginning of the 80s, coronaviruses were not very well known. These were round form shaped particles in stool. That's it, finished. Now we know that they have these common cold coronaviruses, which almost also came from zoonotic bases, from bats and palm civets, for example, and also from cattle and mice. So there was always viruses coming into the human population, and they are now these common cold coronaviruses, which do not make many people very sick. So the first outbreak, Mother Nature's first experiment, what stands up for SARS, severe acute respiratory distress syndrome, was ended in 2003 with almost 8,000 cases and 800 deaths, and was very well managed from the countries where it appeared, mainly in China, because it was not so very transmissible. It was very difficult. It has to be transmitted from lung to lung. And that was good luck for us, because then people were transmitted the virus only when they were sick. That was the big advantage at that time point. But today, with the next generation of SARS-Coronavirus type 2, it's completely different. We shed the virus even also with super spreading events before you get any type of symptoms. And also these ones, they came as the first SARS-Coronavirus at the beginning of the 2000s, coming now from bat. It has of bat origin, and it's closely related to that. And it's still a mystery. We do not know how the viruses entered into the human population. It's still a matter of debate, but it's definitely not coming from a laboratory as a bioweapon. So some numbers, what you see here, that was when I was giving the first talk about epidemiology of the new COVID-19 global cases in March. It was 114,000, so not so many. And now that's what we have right now. It's about now 52 million cases. That is an increase only in 238 days, more than 460 times, in the death increase rate of about more than 320 times. That is a very short interval. So we have a very severe problem on the planet, and it depends on us that we can regulate that. And there's a difference. There's a complete difference between the Western states like Germany, United Kingdom, United States, and also others, just these three examples, compared to Asian states like Japan, Singapore, but also Australia and Cambodia, Thailand, and Vietnam. They have very low cases. Given here is the daily new confirmed COVID-19 cases per million people. Germany, we have 215. At the same time point, just per day, we have 6 in Japan. So that is a tremendous difference. And that is why we have a very severe problem. But in Japan, they do not have that problem in that exercise of numbers. So that is due to mainly cultural differences, that people are not really recognizing the danger of that. So the awareness of that is completely different. In Asia, the people know SARS from, especially in Hong Kong, from the first outbreak. So they have good awareness of that. Here we have less good awareness. People are not wearing masks, for example, and they do not keep distance and all these standard rules. So there is something that the general population at the moment is not playing the game with us. And the different view is that they can't see the virus. They can't see the damage the virus is doing at the moment. And that's a lot of people also in the States. They do not believe that this really exists, or that is at least a problem. For example, in South Dakota, in the United States, 60% of the tests which are performed are positive, 60%. And that is a pity, but that's reality. And then there are also people arguing, well, there has never been an excess mortality and the virus is not as seasonal flu, and that's all rubbish, completely wrong. This is European Mortality Monitoring Activity, EMO studies, measuring excess deaths. And what you can see here on these different curves, that all age groups, these are the 2 flu peaks, and this is the first, in the first wave, COVID-19 cases. It's not occurring in young people, but it starts at 45 up to 85 plus, while we always have in the measured European countries an excess death rate. So it's completely wrong. And now we are here, and that was only the first tip of the iceberg. What will come here, we will see, because it's still in the future. So the argument for there is no excess death rates is wrong. So there are different pathogenicity factors, different virus strains circulating in different populations. That's correct. There's now a variant spreading within the population, which is much more efficiently affecting cells and is thus more transmissible, but not making a more severe pathogenic effects. That's the case. And we have viral adaptation to the new host. That's always if a virus changes the host. And we have cell tropism, like endothelial cell tropism, which can then come out with completely different severe side effects, like heart attack or severe neurological diseases. And we have also a very important factor is the efficiency of the host's innate immunity. And it's well known now and was recently published that that mutations in the interferon beta and interferon to type 1 interferon pathway lead to a more very severe outcome when different factors are targeted, like interferon alpha receptor, for example, IFNA1 or TLR3 or EFR7. And also different populations might have different susceptibility due to different expression of the ACE receptor. That is still a matter of debate. And very recently published, there's a cross protection due to immune responses to related viruses due to cross-neutralization activity with other coronaviruses in adolescents and in children. So I think that's the shortest summary of the pathogenicity at the moment. And now we come to what we call diagnostics. Of course, we have all the tools: PCR, rapid antigen test, virus isolation only in BSL-3 laboratory, thus in Brandenburg not possible. There's the route map coming from WHO, of course. Screening method number 1 is PCR, all of you know. And if this is positive, it's a confirmed case, no doubt about it. If it's negative, it can be still positive, and you have to repeat testing after 4 days, for example. And then if it's positive, it's a confirmed case. Serology measures antibodies only, so it's for serosurveillance. It's not, you're not able to say anything about immunity, but there are assays which are like a line assay pointing out. Also, they are made in Brandenburg, for example, for some companies, where you can really say the antibody is binding to which type of a protein or to which viral protein. Altogether, more than 90% of the people which are tested positive in any of these tests have neutralizing antibodies included in this test fraction. So immunity is still a matter of debate. We do not know how this contributes really to immunity, how long this will last, which antibodies you need, how the titers are. That is still all open and must go under research now, and it is still. So that is something we have to learn. The national test strategy from the Robert Koch Institute and the Bundesministerium für Gesundheit, you can see here. I think everybody knows that the PCR is the main test where we rely all our diagnostics on in symptomatic persons. In the general population, contact tracing, if you have contact to a confirmed case, you should be tested like this, or in the same household, for example, in hospital environment, patient before they come and join the hospital in case of outbreak among patients. Screening should be PCR based, or in the personnel. I think it's quite important to clearly point out that outbreaks in hospital are associated with the personnel bringing the virus into the hospital. That is something we have to aware of. It's mainly not a nosocomial outbreak by patients. It's mainly that people who are working in the hospital are not feeling sick, have no symptoms, that they bring the virus into the hospital. That is so these we have to discuss later on how we can get rid of this problem. Is there a strategy about that? And so that's the way I think we work at the moment. Of course, there are antigen tests. Antigen tests are not that so reliable as molecular tests are. So they are less sensitive, for example, and also less specific. I know that people have tested that with very nice numbers, but it depends on the population you test. So we have always to be a little bit cautious of that. And so for me, POCT is as an add-on test to PCR. So an antigen test is a point of care test. There's a big problem in pre-analytics. People have to handle it in the right way. There's no direct correlation between infectious viral particles and antigen detection limit. And the WHO standard is that at least 10 to the power of 4 genome copies per milliliter should be detected. I don't know if all of those really reach that. I doubt. And a negative result does not exclude SARS-CoV-2 infection, particularly in situations where a false negative result could have serious consequence, for example, introducing the virus into a hospital, for example, on an intensive care unit or in the home of the elderly, for as two examples of that. And a positive result must anyway confirmed by PCR. So why not do PCR right now? And in a low prevalence setting, and low test specificity would result in a high number of false positive results and a corresponding additional burden to the public health service. So that is also increasing the workload of those people. So we have also discussed that. Well, what we need is reliable NAT and NAT, what's working to screen hospitals, home of the elderly, and also people working critical infrastructure, keeping our society running, like employees in energy, water, and communication companies as one example, and others, of course. And that is something we have keep an eye on, that we keep our society running. Well, that is the data from Robert Koch Institute about test capacity, which has 9 times increased in 33 weeks. The numbers you can see here, from 180,000 to more than 1.6 million tests. That is a huge work which has been done for all my colleagues in the laboratories working very hard in routine diagnostics. I know it very well from my wife. She's engaged in that business. So that is a very huge work, but still we have a sample backlog, which at the moment from the data from Robert Koch Institute is about 60,000. So we are not fast enough, and we have an increasing number of positive tests in 10 weeks, 9 times from week number 35 to 45. We have from 0.86 to 7.88%. That is a tremendous increase. In general, I know from different colleagues working in different labs in different areas of Germany that it can also be up to 20% positives, depending really on the local area, and even more and what you get on a daily. This is an overview of overall, but that can be completely different. So there's a lot of work to do to get all these data together. So how many tests do we need? In Germany, there are people making mathematical models which are discussing about we need 8 million tests a week. Well, I think quite up to my personal opinion, something what is, well, not possible. We do not have the people and we do not have the capacity, cannot be extended like this because it must be done by people who know what we are working about, and about 55 million in Europe. So might serology help? No, not really. Serology can determine the number of people who have been infected, numbers of changes over time, but cannot determine immunity because we do not know which titers we need. If you make an ELISA test system on any other test system, line assay or whatever, you do not know, even if you have antibodies against the neutralizing domains carrying proteins, if this will really help. That is very, very difficult. So it's for monitoring the spread of the disease in the population, yes, but I think that's all that you can say about serology at the moment. Is there a solution? Because we are facing a problem which is on a daily basis increasing. Yes, I think there might be a solution. We need an easy to use any nucleic acid amplification test system, a NAT system, what you can use as a POCT. Is that possible? Yes, I always say yes, because we have done a lot of work using with other viruses, dengue, Zika, and so on, using recombinase polymerase amplification system, which is an isothermal amplification using only 2 primers and is really a single temperature and is very, very fast. And I don't want to go into detail to that. Its difference to PCR is that the primer is covered with a recombinase, so heat is not opening the double-stranded recombinase doing that. Then it's opened by a single-strand binding protein, and polymerase is then making the complementation synthesis of the strand. So that amplification procedure is quite well working, and the specificity is measured using an exoprobe system like real-time PCR. So we have done that also for SARS-CoV-2. As you can see here, we are very sensitive, about 10 genome copies we can detect, has all been published in Clinical Chemistry in August and was first published online in May. And the specificity it's the same, it's very highly specific, can be done in a very small volume of below 10 microliters, for example, and thus it's very easily possible to use these type of test systems also in point-of-care devices where you have not so much space. And I think the curve is quite clearly pointing out that this is very specific. And if you make a probit analysis, you can detect below 10 genome copies. So, well, we have a system, and this system is also working with clinical samples. As you can see here, we've taken 20 from our source, routine laboratory. And I can say that there is 100% compliance with RT-PCR, equal sensitivity and specificity. So there might be an assay which might help. And there's a company I didn't know before. I just met very recently. They are called Midge, sitting in Berlin, a small startup company. They have checked our paper, and they are coming from a complete other field, also from electronics, for example. And they have developed the following system. You have a cartridge like this one here. It's half size of an electric toothbrush. They have a readout system and a heating system, which is this one here, with about $29. And you can put on your swab, you put it inside, or you can make it from the throat. And then you turn it around, you put it in, you close the lid. You have then to scan it to your mobile phone. There's an app working up all that. And then you have to turn it around, shake it, and then it takes about maximum 15 minutes that you get a result. And it would also be possible, that was my idea, because it's a notifiable disease. You cannot have a positive result and then hide away. So if you can use your mobile phone to make an automatic transmission of these data to your local public health service center. So that is an option, I think, where we can overcome one of the problems we have, antigen tests, which are not so very reliable, but better to have nothing compared to that. This one is not very expensive. The hardware is the app is just for free, and the hardware is about $29 or something like this. So that is something I think we can use, and we can try to bring that forward to solve our problem. And it's a little bit also like the mobile molecular diagnostics in your pocket, and it offers a change of thinking about mobile diagnostics. So last slide, let me give you some comments or some arguments. What is our problem? How can we solve that? So we have improved public awareness, and our politicians, sorry to say, but that's reality, they have made a zigzag course in giving information to people that is not very well, because people, they do not trust you anymore. In Asia, people, they trust their government, and they behave as they suggest. Here, if I look to Leipzig, Querdenken, we have not this situation. That is a pity and also a danger for all people. And so we have also to combat truth decay. What is this sociological problem we have also in other areas of our society? There's a very sad thing I heard this morning from a friend of mine who's working in South Dakota, where they have 60% positives. People are in the hospital, and they say they don't have COVID, they have severe COVID clinical course, they are shortly before getting oxygen, and they say no, they don't have it. It's all coming from the Biden administration, such things. And we have a little bit similar things here in our society. It's a pity to say, but it's reality. So we have to combat this truth decay. It's very, very important. And we have to make a consistent implementation of hygiene rules, distance, mask use, hygiene, ventilation, and also the Corona app, which is not available for everybody who has a mobile phone. That's a pity, because if you have a mobile phone that is not possible to trace that back, I think nobody will buy another mobile phone to get the Corona app. This must be changed if it's possible. And consistent implementation of hygiene rules in the public and in all sectors of society. Well, this also includes schools. In schools, we have a mess of hygiene handling. And many, for example, I know it from Saxony where I live, it's a catastrophe how this is organized. I have to say that directly. And we have to play the game with the rules. And this is also for all sectors. And all people, adults and kids with respiratory symptoms, should stay at home for at least 7 to 10 days. This should also be something we should implement very soon. And we have to protect vulnerable groups and test them on a regular basis. I think there's no way to stop that. Also, our testing strategy should go in this direction. And we have to implement other test systems for home testing, which would allow real-time monitoring of the outbreak at home. And with that, I leave you and hope that we will have a nice discussion. Thanks a lot.
Okay, thank you very much, Dr. Hufert. Do you hear me?
Yes.
Thanks for your talk. I collected the first comments and questions and would like to pose them to you right now. The first one was a positive PCR test could also be or can also be a false positive. So how can you say it means it's a confirmed case? Well, one of your early slides.
Yes, that is if the test is correctly carried out, the sensitivity and specificity is almost 100%, and thus it's a positive PCR test is positive if there's a low number of people and there is a problem in the pre-analytics or in exchange problems in the laboratory. There can be also a wrong result due to the tremendous workload in the laboratories. If you get 2,500 samples per day, you have to manage that. Of course, there can be a false positive or also a false negative result if during that circumstances, but the assay per se with more than 99.9% sensitivity and specificity is not the problem. It's handling problem.
All right, so that means the positive PCR test will not get rechecked with another PCR.
No, there are two assays are made, two PCR assays are made in parallel, I think, and if these are both positive, then it's fine.
Okay, and I have another question that goes to the number of copies, the relation to the CT value in an RT-PCR.
Yeah, let's say it this way. The CT value is just, well, it's very difficult to compare CT values because different assays, also other nucleic acid amplification systems are using other standards and other technology, which might even not have a CT value. The comparison of the CT values is depending on the assay, and between different assays you cannot compare. So you need a defined standard on numbers of copy you are using, and then you make a classical quantitative PCR. But to compare CT values, it's very crude method to do it, and I would not rely on that.
Okay, and is there a correlation between the CT value and the number of copies?
Yes, it is.
Okay.
The more you have, the lower the CT value is.
Ah, okay, I believe that.
The SEA has other CT value than SE type B, for example. And these two you cannot compare. Of course, if you have high copy numbers, you will have the amplification. Comes over the threshold earlier than you have lower copy numbers in the system. Of course, that's correct. But to really determine the copy number, you need a quantitative standard.
Yeah, and maybe in this discussion, we should pick up the people that do not know what a CT value is, or just briefly explain it.
Cycle threshold.
Okay, so that means if I start with a certain number of copies, then the amplification works in a way that in an earlier cycle, then if I have only background, my amplification of this certain type part of the genome.
Like this, it goes like this. You come over the threshold, you have an amplification cycle which is heating, annealing, this classical PCR cycle, and then melting up again. So that is how it works. Then, if there's a high copy number in, and you have this amplification, it starts from a higher starting point, and you come over the threshold that you can see the curve coming up earlier. In case that you have a very, very low copy number, let's say 3 or 5, or let's say below 10, or even less, 1 copy number, then you will come up with a curve much later. You need more amplification cycles. That means that if it comes over the threshold that you see it, will take more time and more cycles to amplificate it.
Okay, perfect. Let me go to the next question, but you are all welcome to join the discussion. I'm getting more and more messages. The next one would be, what is the correlation between percentage of positive versus the increasing of testing capacity and versus the test quality?
Well, the test quality, the assays we use are all PCR assays, or some other ones like the Hologic system, for example. I think that's all comparable. I would not have any problem with that. Increasing test capacity, yes, that is always the argument that we do not have really more cases. But if you look at the intensive care unit, the question is quite easy. Yeah, you can see up the final end readout of the population, of the infection dynamics we are facing right now.
So you mean that even if we wouldn't test, we would know that there's a much bigger infection wave happening right now because we have numbers from the intensive care units?
Yes, we have numbers from the intensive care units. It's increasing problem, of course, and the test capacity has been increased. That's correct, and we are testing, but we are testing mainly also people with symptoms, and I think this correlation cannot really be made. It has a severe bias.
Okay, all right. Shanling Yang, if that answers your question, I hope. But if not, please just write me another message. The next question would be, China now asks immigrants for a fresh RT, PCR, and antibody test. What is the strategy of this approach?
Well, if you enter a country, you will get tested. You know that to the time point when you are negative, then you know that at the time point it's very highly likely, and you get tested by PCR, and then you know that you are negative. But the antibody, well, maybe the strategy is, if you're negative and you have already had COVID and you have never had any clinical symptoms, and you have an antibody which might protect you, you have a lower risk. I think that is behind the curtain in that strategy. However, we have no formal proof of the protection of antibodies so far. We do not know how high must the titer be and how high must the titer be of neutralizing antibodies that I will be protected. We have had reinfection, even people who had already had that. Very, very few also had severe disease. This was published and occurred in Korea. And so, well, I would be a little bit careful about that I say antibody that would protect you at the moment. We do not know that really, how long protection really holds true, how strong that is. And do not forget, CDL response is also very important. This has also been described, and we know that people from the SARS-1 outbreak at the beginning of the 2000s, people until today have T cells which are reacting against SARS-CoV-1. So we cannot really be sure that this antibody will protect you.
Okay. And what does not come up in this question is how the Chinese authorities react when you have a negative RT-PCR test and a positive antibody test, for example, or the other way around, or both might be positive or both might be negative.
I can, if you both are positive, well, then you would be maybe a reinfected case or something like this, when you would directly go to quarantine. That's correct. But how the Chinese government would make any decision, I can't tell you. I can tell you from Hong Kong that everybody who's entering the country goes into quarantine. That's it.
Even though there's no test positive or anything?
Yes, everybody goes directly.
Okay. All right. I have another question here. Going back to the CT value, it's more a contribution. For a CT value to be relevant, you would have to standardize the swapping process. I think this goes into the direction that you mentioned before.
Yes, that's the swapping process has been standardized. There are a lot of paper out there who have compared everything with everything, swapping nasopharyngeal swabs, only throat swabs, then saliva, buccal swabs, and overall, I think if you look at the paper published so far, there is no big difference. So I think even in saliva, 95% of those which are positive in nasopharyngeal swabs are positive, for example. But may also depend a little bit on the time point when you take the sample. This has so far, up to my knowledge, not really in detail been investigated.
Okay. All right. So there's yet another question by Mr. Nielsen. Is there any point in conducting only an antibody test? It can't show whether a person is functionally immune against COVID-19, and it gives no indication of whether a person has an active or contagious infection. So what's the point?
Why make an antibody test?
Yes.
Yes, to know the infestation of the population.
So it's rather for screening bigger numbers of people.
No, that you know, infestation means that you know how many people have already been infected in the population.
Okay.
So we have two ways of how this will go on in the future. The one way is that the virus is running through the population and it's making at the moment a very good job. So we are not making such a very good job at the moment in the Western countries. And we also have to stop it. And that's what we are now also doing with all the restrictions we have, and to slow down the progression through the society to keep the health system running, that everybody can be treated. This will definitely happen. The virus will not stop at all. It will directly go until herd immunity is there. Can take still years.
Okay.
And the other way is we have a vaccine. And the vaccine, on the other side, you get the immunity by vaccination. These are the two ways, and the vaccine is not making something different. It makes a neutralizing antibody, it makes a T-cell response, and hopefully an immunity. And to know if somebody, for example, working in a hospital is immune or not, we have no real data, but for these people, an antibody test may also be with some benefit, but it's not really formally proven.
All right, okay. The direct answer from Mr. Nielsen would be, I see this makes sense from an epidemiological perspective, yes, although it doesn't help the individual patient much,
Correct.
except for
Correct.
the vaccine aspect, maybe.
Yeah.
Thanks for the answer, very helpful. The next question would be, I'm sure there's more, yeah, there are more coming in. Is there a plan for a commercial introduction of the RPA test that was described? I believe it's the Midge Medical.
Well, this is something that Midge Medical at the moment is working on, and they really try to do that. This is something that you have to contact the company, but I'm sure that they are planning that and that they'll do that. And I hadn't had any contact to them before, but the idea is brilliant, I think, and this should be developed very soon and should also be supported by money to get the system running. And not in 2 months, right now.
Okay. The next question is, when do you expect that the antibody test will start to be more popular?
What is popular?
Yeah, it depends on the perspective, I believe.
Well, antibody tests, the tests we have at the moment, there are a lot of tests which are very good, but they cannot change biology. Yeah, we need to know the titers. We determine that we have protection. This will come out with further studies, and it's too early to say anything on that topic at the moment. But from an epidemiological point of view, it's very, very important to use all these tests.
Okay.
To make a serosurveillance, because it shows us where we are standing with our infestation.
Okay. I see there's a lot of questions here as well. Good day. What can you say about the type of sampling in relation to the concentration of virus particles? They always say that it has to be made by qualified personnel to be sampled deep enough in the pharynx.
Yeah, I think I already said that there are studies that with 95% overlap, you also can use saliva or buccal swabs. Then you have 5% rest. And so this sample can be taken by somebody. And if you have a video instruction, this would be. Even there are people I know in Berlin who are general practitioners who under supervision have carried out, the patients have carried out their swabs on their own. If you would avoid to take a nasal swab, because that is people would not do, because this has to go deep into the nose and is something which should be done by somebody who knows what he's doing. But a buccal or a swab from the pharynx, I think can also be done by somebody else. At least saliva investigations, 95%, same result as with 100% correct done swab procedure.
Okay. Right now I have 2 more questions that refer to the topics we already have, and then I would ask Professor Roggenbuck to post this question publicly if possible, otherwise I will take over as well. So the first one again goes to the CT values. Is it possible to correlate the CT value with the viral load in the patients, or does the process of sampling, e.g. amount of cells that is taken, interfere with it?
Well, of course, the CT value gives you a rough estimation about the viral load, which might be, but you must know your test system, but it can't tell you anything about the number of infectious viral particles which are inside. So infectivity, and still I have to point out, we do not know how many infectious particles you really need to get infected. And this even might be different from individual to individual. So copy number correlation, yes, roughly yes, if you know your test system, and but that's it.
Okay, but the information I got is that basically all mankind is naive to the new virus. So
yes, correct. Everybody has a chance to get infected. That's correct.
And it would be meaning that one virus particle would be enough, probably.
No, that's not. One viral. First of all, if you have 100 viral particles, only 1% might be infectious. The rest is just defect, doesn't work, or maybe
Okay.
depending on the virus. And then it depends on the susceptibility of the individual host. And if you might get even not the virus into the cells due to physical factors, for example, density of the mucus for that it cannot reach the receptor. So not every single virus entering the host will definitely have success. It will be a minority. But if you look, you have 1 million viruses coming in, there might be 1 or 10 which are enough to infect you, and then the whole thing starts. Yeah.
Okay. I have one question here. I believe it refers to the Midge medical gadget. It is posed that whether it is certified internationally. I believe this question belongs to that gadget.
Certified internationally. Well, that's all on the way. You have to contact Midge for that. And to say it here also public, I don't get any money from Midge. Yeah? We have published the manuscript, and that's it. Yeah.
Okay. And now, Professor Rongbrook.
Yeah, well, Frank, can you hear me?
Yes.
Well, Frank, thank you very much for your enlightening talk. I learned a lot today. The question which I have is related to the generation of immunity in infected people. Well, given the fact that we see a very low rate of reinfections, I mean, from my point of view, these are just anecdotal cases yet. Well, don't we have indirect proof that, that the infection that is seen in patients, and the generation of antibodies should have a protective role, and by doing so, generates a certain immunity against reinfection?
Yes, I'm on your side by heart, by data. It's a little bit difficult. Yes, I would say a scientist should never say I believe, but I think it's quite obvious that neutralizing antibodies make certain type of protection. But what we are measuring is antibodies in serum, not on the mucosa, for example. That is one thing. That's a different story, maybe. And of course, it's likely that you will have some kind of immunity, and you also have neutralizing antibodies that can be measured, because we know that the majority of assays detect 85 to more than 90% also measure the neutralizing antibodies within the whole bulk of all antibodies which are inside, but you never know if they are in or not. Well, there will be a protection, and also I think there's a protection against reinfection, but how solid that is, and how long that lasts, and how many antibodies you need measured by a certain test system to say to somebody, well, you have already been positive, you are highly likely to be protected, and you can go on working on the COVID intensive care unit. Well, I don't know. That is something we do not have. But in principle, you are right. There is an immunity generated, and this will also protect. But the question is how effective that is. We have so far, up to my knowledge, no good data. But if you see that we have a slight cross protection in young children and adolescent people, which have antibodies which are targeted to the S2 domain of SARS-CoV-2. So if that protects, at least in part, it's very highly likely that at least a partial immune protection is there if you measure antibodies, especially if you have these domains included in the assay. Or you can even separate by line assay or using these proteins separately, then you can hope for it that it will work.
Well, as a matter of fact, that brings me to my second question. And Mr. Tonagel, if you allow me to put forward this question, can I do so?
Yes, of course. Yes.
Well, Frank, for me, from an immunological point of view, it's quite intriguing to see that IgG and IgM occur simultaneously. Well, and with the theoretical knowledge that we have with regard to infectious viral diseases, we would expect during a primary immune response that IgM occurs first, and then we would a little bit later see the seroconversion for IgG. This is not the case here with the SARS-Coronavirus 2. So, well, my understanding is that we should have then sort of an immunological memory, and you already touched upon this point. Maybe these common cold coronaviruses can give us this memory. What do you think about this phenomenon?
This has been proven that there is at least in young adults and also in children, these antibodies have been shown. And so I think that that is correct. For the IgG and IgM, well, there are also other viral infections like hepatitis A, where usually you have a quite similar upcoming from IgG and IgM simultaneously. But of course, this is a very rapid recruitment, maybe a rapid recruitment of antibodies. So you might be right.
Thank you. It's always nice to hear that I could be right, you know.
Well, you know, it's always the could.
Yeah, well, I understand. Yeah, we should be careful. And in particular, when it comes to coronavirus too.
Yeah.
All right. Thank you.
Welcome.
Okay. Yes, if there are no further questions, then I would ask Dr. Jörg Hollett to do the final announcements. And
yes, hello. Thank you very much. So thank you all for this splendid time that we spent here together. Professor Hufert, thanks a lot for this information. I think that was very enlightening, as Professor Roggenburg said. Dear Dirk, thank you very much for the discussion. Dear Hannes, thank you for summing all this up and presenting all the questions. I think we as a diagnostic network will follow that path further on. So the channel and the chat is still open in a way that you can address Hannes Tonagel directly with further questions. Please be so kind and visit us as Medica diagnostic-bb.de so that you can get into the discussion with our exhibitors. We continue to move forward in terms of diagnostics and do anything that we can to fight this pandemic. And we have to do this in cooperation. So those people like Professor Hufert are absolutely essential for our progress there. So I'm very much looking forward to further cooperation. I think we are very good in time. Very much looking forward to meeting all of you in one way or the other on the Medica or otherwise. So for today, I think we've moved our world a little bit forward with this discussion. Became more confident in what we know and what we do not know. and it is more clear what we have to do. So diagnostic has to help to fight this pandemic, and testing, that is of the issue. We have to move on forward with that. If we know and measure it, we can manage it. So that is always the same thing. If it's unclear and unknown, we are afraid of the black man, the bad guy, in a way, however you would like to put this. So that should not be the case. Spend some, let's put some light on it, and then we move forward. Again, thank you very much. Have a good day. On behalf of the Diagnostic Network, it was a pleasure. Thanks a lot. Bye-bye.
I have one more regard. The medical at medical.diagnosticnet-bb.de also shows you the whole talk again on demand if you would like to rewatch. Sorry? Yeah? Okay. All right. So our experts and I will still stay in the call. If you have some questions that you didn't want to have posed to all the almost 50 people, then we are still at your side and can talk about more details if you like. Thank you very much.
Thank you.
Thanks. So can I log out now?
Professor Hufert, I would ask you to stay for another few minutes, just in case there's somebody that would like to talk to.
Okay.
To us. Okay.
Johannes, das kam nicht so ganz rüber. Jetzt kannst du noch mal sagen, dass der Vortrag veröffentlicht wird auf der Medica-Seite bei uns. Das ging jetzt ein bisschen unter.
Okay, so in case I was muted or something, you see still the screen of Professor Hollett, and at our page medica.diagnosticnet-bb.de, you are also able to see the talk of Mr. Hufert and the discussion on demand. Just go there, click on webinars and scroll down. There you will find the talk again and all the other talks that come up during the week. Tomorrow throughout Thursday, we will have a wide variety of diagnostic topics covered in our webinar sessions. Okay. All right. If there's no further questions, I see all still more than 20 people in the call. Then we will end this call right now. You have seen how you can contact me, and I'm looking forward to your emails. Visit our booth. Thank you very much. Thank you, Professor Hufert, for your time and your nice talk. Bye-bye. Thank you.
Bye-bye.
Thank you, Jörg Hollett, for the introduction and the end note. And thank you, everybody that is still in the call. All right.